Good morning, everybody. Welcome to Beyond Telehealth. And I'm Dr. Lisa Finkelstein. And today we're going to talk about remote patient monitoring. What is going on? I have two special guests. We have Amy Surdam and Dan Surdam, who are husband and wife, I have to say. And they are forward thinking champions of telehealth, telemedicine, digital health, and have a remote patient monitoring company. And I'm going to have them introduce themselves, and we're going to go back in time, and then we're going to talk about their new venture with their RPM business. So Amy, you go first.
All right. So I'm Amy, and I'm a family nurse practitioner, pretty much from Wyoming since '85. I went to the University of Wyoming for both my degrees and have been working with Dan in urgent care, telemedicine, remote patient monitoring for about 15 years now.
Great. Good morning, Lisa. Thanks for having us. My name is Dan Surdam. Born and raised in Wyoming, went away for school and residency and came back to Cheyenne in 2005 to run an emergency medicine group here in Cheyenne. At the same time, kind of a few years later, started in the urgent care sector after realizing the need for better access for patients, because many of these patients in the emergency room were seeking care inappropriately and realizing that much of this could be handled in the outpatient setting if we could just solve the access problem. And then, I think you and I met through various leadership activities in Wyoming and really forged our friendship in 2017 when we were trying to push out telemedicine. And that's really from our urgent care centers. We started our telemedicine initiative in about 2017 and trying to get that rolled out. And as you know, pre-pandemic, post-pandemic, different story. And pretty much during the pandemic, started thinking about how to deliver care in a more efficient, real-time way outside of telemedicine. And that was kind of the inspiration of our company, InstaClinic, which is a virtual healthcare company that dabbles in both telemedicine, but our main focus currently is delivering remote patient monitoring.
Well, we definitely go back pre-pandemic, and I'm just going to mention that when we first started talking about virtual care and bringing healthcare to the patient, everyone thought we were crazy, or what they just didn't understand what we were talking about. And the pandemic was the trigger for this innovation, and people were forced to understand telemedicine. And remote patient monitoring is the next step of virtual care, but we're having trouble, similarly to when we were way back in 2018, trying to convince both physicians and patients of why this is really a great idea for so many reasons. But we're going to talk about the good and the bad and the ugly of remote patient monitoring. So why is it a great idea? What are the patients? Who are the patients that you guys think that this is the best use case scenario? I'm going to start with one thought, and then I'm going to pass it to Amy. So initially, the really the highlight for me during COVID with RPM was the few hospital systems that were forward thinking said, okay, our ERs are swamped, our hospital ICUs are overloaded, and these patients are coming to the ER. They're not necessarily sick enough to be admitted into the hospital. We're going to send them home with a goodie box of a few things: an iPad that has a platform downloaded like Zoom, because everyone was familiar, a pulse ox, a thermometer, and maybe a blood pressure cuff, and a plan and instructions on how to use these devices. So they go home and they say, okay, a nurse is going to check in with you twice a day or a few times a day, put eyes on you because you're going to click on Zoom, and we're going to measure these things. And that information is going to be uploaded to a dashboard. And we will determine whether or not you can stay at home, be safe, or you're not doing well and you need to come back into the hospital. And that was a great use case scenario that was very successful to keep patients out of the hospital, in their home, and safe. So, Amy, you take it from here. What do you think?
So, as you know, somebody needs to have a chronic condition to be able to utilize telemedicine or remote patient monitoring and have it paid for by the payer. So we're looking for patients that have a chronic condition that needs to be monitored, such as hypertension, diabetes, obesity, congestive heart failure, anything along those lines, and it's pretty vast. We're also looking for patients who are engaged in their health and want to participate in their healthcare journey and want to improve their health and monitor their health. That patient engagement, patient desire piece is very important. We also need patients to be tech savvy and understand a little bit of the equipment and the software, and somewhat independent, or have an engaged family member or friend or caregiver who can assist them. So those are our kind of ideal patients. Yeah.
Okay. Dan, what can you add?
No, I think so. Those are the ideal candidates that have a chronic condition, that are engaged in their health, or have limited access to healthcare. The best patients are those patients who, day in and day out, are writing down their vital signs in this notebook, and taking that notebook into their primary care provider or their cardiologist and say, no, here are all my vital signs for the past year. Can you please, extrapolate all this data in 3 minutes and let me know how I'm doing? But usually the providers are relying on that snapshot in time, that, the vital signs that they take at the office, which are not accurate, as we know. There's the white coat hypertension. There's all sorts of things that go into why that one blood pressure reading is just not useful to anybody. So those are really the patients that would benefit the most. And anecdotally, we've had some amazing saves. So at its basic, remote patient monitoring is you're taking a device, either a blood pressure cuff, a pulse oximeter, a thermometer, a scale, that can be connected to the Internet of Things, either through Bluetooth or through cellular. And that data is fed back into a software platform where you have your care team monitoring these vital signs real time. And so you're not waiting a year or 6 months or even 3 months for something to show up. We are proactive. We're not reactive. We're watching the trend in these vital signs. We're able to extrapolate the data to look at it in a meaningful way and give that feedback to the providers who are taking care of the patient.
So for instance, yeah, go ahead.
Sorry, Lisa.
No, go ahead, finish.
I don't want to segue too much, but so that the chronic care population is where RPM started, but now we're seeing an interesting trend in younger people who are just interested in health hacking, that say, hey, I would like somebody to kind of monitor my vital signs and give me feedback. And so that's kind of an interesting trend that we're seeing in the market right now, is where you have young, healthy people who really want to try to dial in on their health as much as they can. But our focus as a company right now is with the chronic care, people with chronic conditions, and delivering care in areas where access is limited or tough to get to, or they can't get in to see their providers.
So if a patient has congestive heart failure and is weighing themselves daily or often, and you see a change in their weight, you can look at their edema, and you can tweak their diuretics or tweak their medication and potentially avoid either an emergency room visit or a visit to their primary care or cardiologist. where they don't have to come in. I mean, that's a beautiful thing.
Mm-hmm.
It's amazing
Right.
because as we know, once they go into the hospital, the chances that they're going to go home are slim because the $1 million workup is done in the ER. There's something else that's found. It's a snowball effect, right? But if you can catch that 5 pound weight gain early, and it really depends on the relationship that we have. We have relationships with providers where we'll call the provider and say, hey, Mrs. Smith has gained 5 pounds over the past week. Can you have somebody call them and adjust their medications? But there's some patients that we have that relationship with that we did not contract through the provider, and so we'll manage the diuretics or say, hey, you need to get in to see your primary care physician, or are you short of breath? What's your pulse oximetry? Are your sats okay? So really, it's amazing what you can do if you catch it early. But by the time we usually catch it, it's too late, and it requires a hospitalization.
Amy, can you talk about how that works a little more specifically? So the
Mm-hmm.
two different scenarios where how does your company work with you managing the situation versus contacting their own physician?
Mm-hmm. So most of our patients we have signed up independently. We really don't have right now a group that we're working for, like a physicians group. So how it works is if the patient signs up with us, I do a E&M visit with them, or an initial visit with them, to get an understanding of the patient and their needs and their medications, and then start them on the remote patient monitoring and do the education. And then if there's an issue, so I have one patient actually just this last week. I've spent a lot of time with her because we started her on RPM, and her blood pressure has been consistently like 190 over 90, and she kept thinking the equipment was off, and and we kept going out and checking the blood pressure cuffs, and I'm like, no, your blood pressure is really this high. So so I did call her provider and told her what we had found and what was going on, and she's like, great, thank you, I'll get her in the next few days, and we'll get her blood pressure adjusted. And so I had that conversation, and then her blood pressure came down, and it's been about a month, and now it's gone up again. And so we had to intervene and escalate the care again. And I just said to the provider, I can adjust it if you'd like, if you don't have time to see her, or if you want to see her, that's great. And she ended up seeing her. So we had several instances where we do call their PCP first and just give, like, hey, this is what we're finding. This is what we're seeing with the data we're collecting. Do you want to see your patient, or do you want us to intervene on your behalf and give you the office notes? And so it's been a good collaboration. Most of the time, each month we will send the report. We have a nice PDF report of the vital signs that we'll send over via fax to the provider's office, just so that they see it, and then hopefully they're uploading it into the patient's chart. And then we have a healthcare navigator that talks to the patients every month and makes sure that they're taking their vital signs, and if they have any upcoming appointments, we'll make an additional effort to get data to the providers. Or if they have any needs that we can help with, we'll identify those needs and try to help them with whatever resources we can.
Wow. Let's pick through some of that stuff. Okay, so let's talk about some of the challenges and the barriers. So first, let's look at from the patient's side. What do you think are the barriers to remote patient monitoring from their perspective? Either Dan or Amy.
I'll start. So initially, just because these are my people. So, initially, just getting them to utilize it. So I have found that some patients feel like it's a scam. We're trying to scam them, and so they are leery.
Why do you use that word? What do you mean?
I mean, I've had patients say that. They're like, well, is this a Medicare scam? Like, my doctor told me not to do anything unless it's through my doctor. I'm like, I'm happy to talk to your doctor and see if they'd like to order this for you, because we do have order forms that for any physician who'd like to order it for their patient. So there's a little bit of a general attitude of mistrust from some patients unless their physician is the one ordering the service for them, even though they can sign up on their own and it's covered by Medicare and most payers. So that's one barrier. So once they decide to utilize the service, I think that a lot of time for Medicare, well, the reimbursement rate, I don't even know, 20 minutes or something to sign them up and to get them going with the equipment is very minimal. And we will spend a significant amount of time with patients with the software and the equipment, just educating them on how to use it. So getting them comfortable with the equipment and utilizing the equipment is difficult for some patients, and we will have to re-educate and re-educate and re-educate. I told Dan this morning, we have a patient we have been trying to pair and connect and get her comfortable with the equipment for 2 years. And she has finally gotten there. And so I was like, this patient is paired and she's using it and it's going now. And he was like, are you finally? So it is.
That's real. That's realistic. I mean, that's a story that's true.
It's true. And she's using it now. And I'm like, yay, finally. So that's difficult. And then once they are using it, since the Federal Emergency Act ended, the 16 readings a month for the reimbursement of the equipment itself is difficult. And we have really found, unless somebody has an Apple Watch or a Fitbit or a continuous glucose monitor, getting to those 16 readings a month is really challenging and almost impossible.
Right. And hopefully they will change that, because
I hope they change it. Mm-hmm.
I think they're realizing that. Dan, can you, because we could go on and on, but can you address, let's go talk about the doctors and the clinicians. What's the holdup with that, with us?
Yeah, I think it could be, a similar story to telemedicine pre-pandemic. It's just we have this amazing technology. The technology is finally at a point where it not only is reliable, it's efficient. The holdup trying to get providers signed up is same as the patients, that you have that trust factor, right? They're like, well, who are these guys trying to talk me into this remote patient monitoring thing, that they may or may not have heard of. So once you get the trust established and, they're comfortable with the fact that you're a legitimate person, a legitimate company, they'll let you talk to them, but then they're so busy, right? They really don't have the time of day to really even consider implementing this. They often don't want to invest the resources. They're not sure the return on investment is there. And so, as you and I were talking earlier, with physicians, it's time and money. And the way that we practice medicine, it's, if those two things are not readily apparent, they're not going to be interested in it. And so even though we can provide them with all this data and anecdotal stories and do some case tests with them to show them how beneficial it would be, until the reimbursement model changes, it's going to be really difficult for us to see a big uptake in provider engagement.
Yeah, we would say prior to the pandemic, in regards to physicians, that they are ultimately worried about two things. Am I going to get paid, and am I going to get sued? Those are two priorities for physicians when they're implementing something new. Let's just quickly talk about reimbursement and how that is a barrier right now, coding and billing. So who wants to tackle that one?
I can talk about that. So every month we are manually invoicing for our patients, and then manually working through the AR, and it's just really labor intensive. There's a lot of denials. We'll get denials from insurance payers who are like, oh, it hasn't been 30 days, because you can only bill every 30 days for some of the one of the codes. And even though it has been the 30 days, they'll be like, it wasn't. So it just feels like a constant fight with the payers. Or just for example, we just had a payer tell us that atrial fibrillation isn't a qualifying condition for remote patient monitoring, so they're not going to cover it. And so I'll be calling the payer to discuss that, but you're just like, come on, like what is a qualifying condition if that's not? And so I don't feel like the payers understand it either at this point, right? And so it's a challenge to get paid. It's a challenge to get paid for the services.
Right. Yeah, so that barrier has to come down as well to get this off the ground. The hospital systems are trying to implement hospital at home, which involves all of this that we're talking about, and I think that those programs have also struggled, and which is really sad. But the three of us are hopeful. We've seen the pandemic change things overnight, and I won't say it out loud, but maybe there'll be another trigger, and that will help us move the needle just a little bit more. The other group that I talk to are medical students, and we go over remote patient monitoring, and they have not been exposed to any of this really. But I say to them that in their career, this will be a part of their life, that they will be looking at dashboards and managing remotely and keeping patients at home. I think this will happen. I don't know how long. Dan, what's your crystal ball say?
Yeah, I think when you look at the 5 stages of technology adoption, we're still in that innovator, early adopter stage. I think 10 years from now, this is going to be commonplace. I think I would say 10 years. It's going to take that paradigm shift from fee for service to value-based medicine, where there's incentive to keep patients out of the ER, keep patients out of the hospital. And until that shift really happens, the reimbursement for RPM the margins are just so small. It's tough to really convince physicians and providers who are extremely busy that it's worth it, because in their mind, they've got to slug through their 30 patients in clinic that day. They don't want to be bothered. So the technology is changing rapidly, though. Even as we speak, there's technology out there where your smartphone, through its camera, will be able to look at your face and tell you what your blood pressure is. And so, there's things out there that are coming. And so my crystal ball would be, 10 years from now, this conversation will be much different.
What do you think, Amy?
I would agree with that. I think it's going to be a long, slow slug.
Yeah. And we had this conversation when we were talking about stitches and your initial company with telemedicine, and literally overnight. So we don't know, right? We don't know. But the fact that it's on everybody's radar, that if, God forbid, there was a pandemic or a war or something, that the technology is available, and we have people like us that can say, okay, we're ready. We know how to do this, which is phenomenal.
Yeah, it was, when the pandemic hit and we looked at everybody else, we were day one seeing patients via telemedicine, where, 6 months into the pandemic, everybody was trying to catch up. And so it's probably a similar situation with remote patient monitoring. It'll happen, and when it does, it's tough to predict, but it's an incredible technology. We've had amazing saves with the patients that we're taking care of. During the pandemic, it was interesting. Nobody went in to see their physicians, and so the patients we did sign up during the pandemic with RPM, one person, their stats were in the 70s, and this is not really a great story, but he went into the ER and he was diagnosed with lung cancer, but would never have even known it we wouldn't have told, hey, you got to get checked. Your SATs are 70%, right? So the technology is amazing. It's just getting both the patients and the providers to adopt it and utilize it.
Yeah.
All right. Well, we're going to leave it at that, and I'm going to end the broadcast. Thank you guys so much. Stay on for a second, and we'll see you soon.
Thank you,
Thanks,
Dr.
Lisa, for having us.
Silverstein.
Thanks, guys.